Welcome to AUHSD Future Talks. I'm your host, Superintendent Michael Matsuda from the Anaheim Union High School District. And Future Talks is dedicated to the future, which is right now. What does a post-COVID-19 world look like, especially for our young people in terms of jobs, access to jobs, workforce pathways. And we know that we cannot address this without several important partnerships from higher education, from business, and from nonprofits. And we're so blessed to have people and organizations that really care. And as our audience knows, one of our biggest partners is UC Irvine. And specifically, we're lucky to have our next guest, Dr. Bernadette Boden-Albala, who is the director and founding dean of the program in public health in the Susan and Henry Samueli College of Health Sciences at UC Irvine. She is also a professor of population health and disease prevention and epidemiology. She brings an amazing world-class experience working with UNICEF and the United Nations in developing curriculum in public health. And as we know, in this COVID world, we are dealing with this horrific pandemic with in a lot of uncharted waters. So we are so blessed to have a person of her expertise and knowledge leading a program with one of our major partners. And we've been very lucky to have Bernadette as alongside us, and many of the professors that she brings along to help us navigate this pandemic. So welcome, Bernadette Dean Boden-Albala, to our show.
Thanks so much, Mike. It's really my pleasure to be here. And I have to say, it's been such a pleasure working with the school district, working with you on all of these partnerships that really began almost at the same time that COVID began. And I haven't been here that long. I haven't been here that long before that. So COVID's a terrible disease, but it has been a wonderful ride working with you.
Well, and you've been brought aboard to try to build a program into a school. Can you help us understand that, and really what was the reason why? Because I'm sure someone of your stature had many options. Why coming to UCI in Orange County?
So I had never left New York before. I was at Columbia, I was at NYU, I was at Mount Sinai. And as I moved from one institution to another institution, I built things. And I think that's what I do. I think I build. And so I was really intrigued when the opportunity came my way to come out to California. It wasn't even on my bucket list to come out to California, to come out to UCI. One of the interesting things in New York was that I was always at private institutions, and public health is not really a discipline where people graduate and make a lot of money. They broaden their horizons, and they feed their soul with good things, because that's what public health really tries to do, is to try to enhance the health and well-being of the community. But one of the things that really enticed me about coming out to UCI was that it was this wonderful public institution, and that meant that we were able to offer world-class public health education to everyone. And again, so we are a program. We are moving now to a school. One of the exciting things about our program is that we have about 1,300 undergraduates. We're one of the largest and earliest undergraduate programs in the country. And it's extremely diverse. About 60% of our students are first generation or low income, and they're going to go back there. They're really committed to serving their communities. They're going to graduate. They're going to go back into their communities. And we want to make sure, I was again intrigued to really make sure that we supported these students in their education so that they could go out and really serve the communities. I was intrigued with Orange County. It's an extremely diverse community, and most of my own research is in the reduction of disparities. And so this was a great fit for a lot of the work that I did, and you know, the chance to take what was already a really excellent program and to build it, to really broaden the disciplines within public health that we could bring to students, to be able to get them not only to have a really solid undergraduate education, but to really expand our Masters of Public Health, which is a terminal degree. And there's tons of people with this MPH that are leading programs, not just locally and nationally, but really globally as well. And so to really be able to bring that to these students, and of course our doctoral program, we really want to enhance and grow that. And so that folks that really want to do research in public health will have access to that, again, at you know, really one of the finest public universities in the country.
Absolutely. One of the things that brought us together was the battle against COVID early in June. And I remember when I first met you, this amazing researcher and leader in public health, but like me, you are a teacher at heart, and COVID-19 is a very big teachable moment for all of us. And right away, you said, look, we are there for you, and we want to train up this. I was learning all new vocabulary words such as contact tracing and contact tracers, and UCI's program in public health stepped up to train with the partnership with Latino Health Access, train many of our adults, our parents, called Promotors. Now, that was another new vocabulary word for me. Can you share what that word means, and why is that such an important word in terms of cultural competence in this area?
So health promotores, they are folks that are really promoting health. And the most important thing is that they're actually from the community, within the community. It used to be that people thought that you could just, that public health practitioners could just go into communities and make changes and then leave, and then that would be it. The community would be healthier and better for it. And I think that was really, you know, those were all well-intentioned, but the truth is that the health of the community, while it needs to be supported by public health and public health knowledge and strategies, is the communities to have and to manage. And so health promotores is one way to have community members really invested, empowered in their health. And these are folks that we train, that help us to translate some of the knowledge that we have about what works and what doesn't, and help and give us feedback so that together we can get into communities and we can really make a difference, and that the difference is sustainable because, again, the community embraces it, and we have people like health promotores, you know, supporting that change for the betterment for health. And so, yeah, go on.
All the promotores are lay people, right?
Yeah. Yes, they are lay people from the community who understand the community. I mean, so you mentioned before some of the work that we had done with the World Health Organization, with the World Food Organization, with UNICEF. And so we were involved, for example, in the Ebola epidemic, which was really dreadful, of 2014. And it was only when community was brought in and not just told, oh, you know, nobody can speak to each other, no one can see each other, everyone has to, you know, isolate. It was only when community was brought in, and that the health experts and the military and the government began to understand the values that people placed in different activities within the community. It was only after having community voice in a participatory process that interventions were created that everybody could live with. And that's how we did, you know, that's how we were able to really intervene in Ebola and you know, turn it around and basically get rid of that terrible disease. And so health promotores, they're interpreters, if you will, of both science into community, but community to science.
So, and I think the biggest thing that they bring is that, like you say, bridging
Right.
the science with the community, but it's really about trust, isn't it?
Oh, it's totally about trust, totally. And I have to say that's one thing that I'm extremely grateful for, is that we were able to establish the program in public health at UCI, the school district, Latino Health Access, the cities of Anaheim and Santa Ana, real trust with each other early, because it takes a long time to have communities trust you. And so having health promotores and working with them and really trying to do things together and understanding that people are not just going to desert you. That's what trust is all about.
So Bernadette, another vocabulary word that I've learned a little bit about is this term called comorbidity.
Yes.
And, you know, when they say that COVID-19 has laid bare a lot of the inequities out there, could you help our audience understand, like, what, again, in lay terms, what does that mean, comorbidity?
So comorbidities mean that you have other underlying health factors, okay, that could contribute to or exacerbate, make worse the condition. And we're talking about COVID, right? So comorbidities of COVID mean that if you have asthma, if you have hypertension or high blood pressure, if you are overweight or obese, if you have these kind of conditions that and you get COVID, that that you are likely to do worse, that your outcomes are going to be poorer unless we can get you and get you in and really try to be very aggressive. And so I would just say, Michael, you mentioned both comorbidities and race ethnic disparities. And so I was just going to say that it gets very tricky with COVID, because a couple of things are happening. First, there are what we call social determinants of health, which are structural issues that influence health, and that certainly influenced COVID, the ability to get COVID or your exposure to COVID, and then your likelihood of poorer prognosis, all right, or worse outcomes. And then combine that with comorbidities. So we know that in the United States, Latinx populations are more likely to have something called a comorbidity called metabolic syndrome. And that means that those populations may be more obese, as I talked about, have diabetes or high blood sugar levels or blood glucose levels, and have hypertension. So they have a higher rate already. Then they get exposed to COVID. And part of the exposure to COVID is because of these social determinants of health, right? So a lot of the Latino population was also the essential worker population that had to be at the grocery store, that had to be in the hospital, in working to support the healthcare system. And so by doing that, the very people with the comorbidities, which would make their exposure to COVID worse, were more likely to be exposed because of these social determinants of health. And it's sort of the perfect storm in a terrible way.
So this is why by July we saw this tremendous spike in Anaheim, Santa Ana, where these perfect storm collided, right?
Exactly.
So what you're talking is about a pre-existing condition for these communities.
Right.
What can be done? I mean, post-COVID, because those pre-existing issues are still going to be with us, right? And that's a serious long-term problem.
Right.
What are some of the things that you think need to be done to change that pre-existing and address that pre-existing condition in these communities?
Yeah, so I think that we have to tackle both issues, the comorbidities and the social determinants of health. Ultimately, if we can change the structure within which people live and work and function to create health equity, okay, that's a big way, because that would have then equalized exposure. And so less people would have been exposed to COVID because we would have had masks earlier on. We would have had policies that would have helped to regulate who, you know, how protected the essential worker was. You know, trying to address social determinants of health is very difficult, because it's not just, you know, I'll give you a medication and you'll feel better. It's about the political structure. It's about the economy. It's really very complicated, but we can work towards that. We can come up with policies, for example, when we tell everyone to shelter in place, that have that really have caveats for people that can't shelter in place, right? So those are things we can work on in the social determinants of health. And in terms of these comorbidities, you know, we've been working on these comorbidities for a while. So a lot of my work prior to COVID was in chronic disease, cardiovascular disease and stroke. And we were kind of yelling to the world, look at these disparities. If you were African American, if you were Latino, you were much more likely to have a stroke than if you were white. And why is that? And so again, some of it's the social determinants of health, and others are these pre-existing conditions, which probably are related again to social determinants of health, but to getting to people early and to changing and making people healthier earlier, working with families, something that I think is critically important, so that we reduce risk for grandma.
Well, this is why possibly the partnership with UCI and other nonprofits to develop the community gardens, right? Exactly. Community gardens is a way in which we can help transform neighborhoods.
Help transform neighborhoods and help to think about living better, living healthier, but in a very culturally and traditional way.
Absolutely. So we look forward to that partnership with UCI program in public health. I'm going to switch over to what's people now are talking about, the vaccine and the logistics behind it. Could you explain a little bit about what are the challenges going forward and that you see logistically with the vaccine? Because some people are saying that this could take a long time.
Yeah, I think that there's a lot of challenges. So I think the first biggest challenge is, you know, are we going to be able to make enough vaccine to cover everyone? So that's the first challenge. And you know, I think that everyone's trying to meet that challenge. The second challenge is identifying and dispensing the vaccine to the highest risk groups first, right? So high risk groups, and I sit on the vaccine task force for Orange County. High risk groups include people with comorbidities who have high exposure. So healthcare workers with comorbidities. We also saw some terrible COVID really, in nursing homes. And so that sort of residential nursing home population would be one of the first groups. And so it goes from there, sort of sickest, most at high risk to the group that gets the population that gets COVID, you know, in a better way, if you will, not as many symptoms, not as sick, which really are children and young adults, although children and young adults have gotten sick, but not at the same rate. And so one is just then, how do we then think about dispensing the vaccine? And one of the other challenges with this particular vaccine is it's not one dose, it's 2 doses. At least that's the early vaccines they're talking about. And that means having to come back twice, not once. So think about the logistics of this. For Orange County, 3.2 million people, trying to assess which risk group people are in, trying to get them to come in, and then come in twice within a month. We don't know a lot of things. We don't know how long the vaccine lasts. So is it going to be a year? Are we going to have to get revaccinated? So all of these things are still up in the air, but we know that right now, Pfizer, for example, is reporting very high rates of success, okay? But the other really important thing to talk about is this concept of vaccine hesitancy. Why is it that people don't get vaccinated? We know that for influenza vaccine, for example, 50% of a population may not get vaccinated. And there are a lot of reasons. And this comes back to community. It comes back to culture. It comes back to individuals evaluating the risk benefit to them of getting the vaccine. And, you know, we think, well, of course, the risk is low and the benefit is that you won't get COVID. But there's really a lot of things, including some social determinants of health issues that people think about, right? Where am I going to get the vaccine? Will I have to take the day off? If I take the day off, will I still have a job? For example, there's a lot of discussion back and forth in California, especially. But also,
I have a question. So you said you have to take one shot and a booster. It doesn't take effect until after that booster.
Right? So the effect is small. And so you really need that second booster. That's right.
Okay. And also I've heard it has to be delivered frozen too. And that's going to be another challenge.
It has to be delivered at -80. And that is a huge challenge. The good news is, I think, partnering with places like UCI, the county will have some freezers as well. You know, in the science world, we're dealing with -80-degree, you know, storage capacity in major universities. So that's actually a good
point about the large number of hesitancy, and you contrast that with the numbers we need in terms of the herd immunity. What is that number of herd immunity?
So the number people are talking about for herd immunity is about 60 to 70% of the population.
But you have 50% who may not want to take it off the top?
Right. So you've had it. If you've had COVID, we believe you have at least some immunity, right? And so we've reported maybe 17% in Latinx populations have some antibody coverage, which is high, 12% in Orange County overall. So you'd need to take that number, then you add the number of people getting vaccines, and you're right, Mike. You're really barely at what herd immunity would be, and so we still may be vulnerable because if we don't get a large enough population getting vaccine, then we really won't achieve herd immunity.
So I'm going to shift again. In the last few minutes that we have, Bernadette, this show is about jobs for youth. What advice we have 30,000 young people and their parents in our district. What advice do you want to give to young people about jobs, and especially like in an area like healthcare?
Yeah, so first, I think that healthcare is here to stay in terms of the job market. And there are many, I would say you want to explore all of the different aspects of healthcare. I mean, if you take COVID as an example, right? You've heard epidemiologists like myself, people that are looking at numbers, if you like numbers, and trying to understand how the disease moves about. We're talking about people who go out there and go into communities and try to promote health. We're talking about social workers, because it's very hard to be isolated for long periods of time. So educators and social workers and public health professionals, and of course the traditional nursing and nursing aides and physicians, clinicians. So there's a huge job market, and it really depends upon where you want to end your learning, your formal learning. If you want to, finish with a bachelor's degree, and you could go into contact tracing. You could certainly work for a Department of Health. At a master's degree level, you could be running programs. At a PhD level, you could be in a university setting, and you could be doing some of the research. I think two really important things. One is whatever you decide to do, you should have passion, and you should really love not only health overall, but the area that you are interested in, and talk to people who do that, and kind of get a sense, if you can go and, spend the day or 2 days or 3 days with them just to get a sense of what they do and what their life is like. Healthcare is all about evidence and science. And no matter what you decide, you think you want to do health now and then later on you don't, learn science, appreciate science, and be able to defend science, because this entire epidemic was all about questioning some key issues with science, and we weren't able to get together and strategize and keep our country, keep our communities as safe as we could have, because people questioned a lot about science. And so I say learn it and be passionate about science and really be able to defend it.
Well, that's awesome advice. We've been very fortunate to have people from the corporate side as well talk about these same issues. And I'm hearing one of the foundational pieces, which is in terms of preparation for this world, is data analytics. And yes, we've had a number of people talk. In fact, we had the dean of the School of Education talk about the importance of sort of cultural competency as well. And these are kind of big issues in education. Do you mind commenting on the importance of those issues as well?
Yeah, well, so I think cultural competence is critically important. Understanding that everybody has a different worldview and that communities have different worldviews. And so we can't move forward without understanding and appreciating and integrating each sort of cultural value system into the way that we do things like design interventions, okay, to promote health and well-being for communities. So that's one thing. The opposite end of that is data analytics and big data. We collect data in so many ways, from our phones to the computer to electronic health records. And that gives us some sense of how we behave, what our health is, again, what our values are. And so by learning how to look at big data and asking the right questions, we may really be able to come up with strategies that, again, lead to enhanced health and wellness for everyone.
Well, Bernadette, this has been a very quick 20 minutes, and I want, on behalf of our 30,000 young people and their futures and their families, I want to thank you so much for this partnership, both personal and institutional. Thank you so much, and we look forward to hearing more of the great work that you're doing.
Thank you as well. Thank you.